Hello.
Professor, I'm sorry, we had some issues.
That's all right. No problem. No problem. Good to see you guys. So just let me know when you want to start.
Hello, doctor. Good
Professor,
evening.
I'm sorry, we had some issues.
Oh, it's no problem. No problem. All right. Let me know when you want to go ahead and start.
Hi, Professor.
Hi. How you doing, Clarina? Good. Good
I'm
to
fine.
see you.
How about you?
Very well.
I'll
Thank you.
be at Tarita's place today because she couldn't make it. Okay?
Okay. Sounds good.
Okay. Can we start?
Yes. I can go ahead and share my screen.
Okay. For the ones who don't know, this is Professor Salim. He's a doctor in St. Louis, and he'll will be with us today for a class about the surgical treatment of aneurysm. And this is our club, the Watery Dang Neurosurgical Student Club Brazil. You can go.
Thank you so much. It's my great honor to be with you guys today here with our Brazil Dandy Club, with the excellent officers of this club. I'm gonna give a presentation, then I will want to give you time to ask me any questions. It's important for you to really follow this presentation step by step to really understand the concept we are trying to give. Today, we're going to talk about a 41-year-old female who had an aneurysm ruptured, and she has what's called grade 3 subarachnoid hemorrhage, which means that she was sleepy, but she's not comatose. You can look up the grading. I rather spend my time in things you cannot find in books. But so she has this aneurysm right here. Now, before we get into this, I have to really explain to you how to look at something like this. This is a place called the anterior communicating artery area. Before we go there, before we do this surgery together, I'm gonna explain to you the idea of the anatomy and everything else, how we're gonna do this. All right. So there are 4 blood vessels that supply the brain with blood, as many of you know. There are 2 carotid arteries in the front. This is the right, we're looking at the front face of the person. So the right eye would be here, the left eye would be here. This is the right carotid artery coming up from the neck, turning in to enter the head. The left carotid artery coming up to enter the head. In the back of the head, there are 2 vertebral arteries, the right vertebral artery, the left vertebral artery join to become the basilar artery. The carotid artery goes up and divides into the middle cerebral artery and the anterior cerebral artery. Middle cerebral artery, anterior cerebral artery. Then the arteries, the middle cerebral artery divides into different divisions, right here and here. Same thing, the anterior cerebral artery turns into a second division of the anterior cerebral artery. We call these by numbers. So if this is the first part of the anterior cerebral artery, we call this A1. This is the second part of the anterior cerebral artery. We call this A2. This is first part of the middle cerebral artery. We'll call M1. Then there is an M2, and there is an M2. M2, M2. So these numbering system help us identify the general concept of these vessels, okay? So we could look at this from very different directions because this is a three-dimensional structure, not a two-dimensional structure, okay? So as you see, we could turn this around. We're looking at the left carotid, right middle cerebral, left middle cerebral, anterior cerebral arteries, two of them, A2 and A2. This is us looking from behind, okay? If we look from above, this whole thing comes around to become a circle. We call the circle of Willis. This is where the two anterior cerebral arteries, the top of the basilar artery, they all connect together to become the circle of Willis. A great view of the circle of Willis from above. You see, I told you about the carotid artery comes up to form the middle cerebral artery, anterior cerebral artery. Carotid artery, middle cerebral artery, anterior cerebral artery, the A1 part of the anterior cerebral artery. A1 part of the anterior cerebral artery. Now you become the A2 anterior cerebral artery, A2 anterior cerebral artery. The aneurysm in the patient we're talking about sits right here, okay? So that is at the base of the brain. I'll show you in a minute. So you keep seeing three-dimensionally how we're gonna find this aneurysm. Now, if we add the brain to what we're talking about here, again, this is a frontal view. The right eye would be here, the left eye would be here. The right carotid artery coming up from the neck to enter, divides into the middle cerebral artery, the anterior cerebral artery, A1. Left carotid artery, anterior cerebral artery, middle cerebral artery. For me to get here, to do the surgery in the patient who has an aneurysm sitting right here, I have to find a natural way to get there without obviously going through brain. So what I'm going to use is the natural highway called the Sylvian fissure. If I can get enter here, enter, come down here, come down here, come down here, come down here, boom, that's where the aneurysm is going to be. So as a surgeon, the first vessels I'm going to see are going to be the middle cerebral artery vessels. Then I'll come down. Then what am I going to see next? I'm going to see the bifurcation of the carotid artery into the middle cerebral artery, anterior cerebral artery. Then I'll follow to find the aneurysm sitting here on this patient. So that's the idea of how you think three-dimensionally to get to this area of the brain, to think about it, and to get to it. You see, this is a natural highway right there. If I can come in here, and come in here, and come in here, come boom, 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 that's where the aneurysm is. That's the aneurysm sitting right there. So obviously, I cannot go through brain. I have to go through the natural fissures of the brain to get there. So that's really how we should look at the brain and how to get to the various areas. So that's the area. That's the area, the front part of the circle of Willis that we talked about. The pituitary gland sits right here, okay? So this is the natural fissures, the natural highways that we will use to navigate inside the base of the brain. This is the base of the brain right here, okay? Right there, this area right here is the base. So that's how I want you to be able to think about how to get into various parts of the brain. So if we look from below, see the carotid artery coming up here divides into the anterior cerebral artery, the middle cerebral artery. Middle cerebral artery, first portion, M1, M2, M2. A1, first part. Then it becomes a second division, A2. Left A1, A2. So there'll be two anterior cerebral arteries here, A2s, and two A1s coming together in the area we call the anterior communicating artery right there. That's connecting the two anterior cerebral arteries. So if we turn this around and look from above, we will see the carotid artery coming up. It divides into the anterior cerebral artery, middle cerebral artery. Carotid artery coming up, middle cerebral artery, anterior cerebral artery. The anterior cerebral artery, this is A1, A2 on the right side. A1, A2 on the left side. The two are connected via a tiny area we call the anterior communicating artery. Our patient has an aneurysm sitting right here. So I talked to you about how I'm going to use a Sylvian fissure to get there. So I'm going to be coming through here, Sylvian fissure, middle cerebral artery, boom, A1, boom. That is the circle of Willis. That is at the base of the brain. Now, I want to get your attention to tiny little vessel right here and right here coming out of the A1 or coming right this area. This is a branch that's called the recurrent artery of Hubner. This is a very important branch because it supplies the internal capsule. If you injure it during surgery, the patient will be paralyzed on the contralateral side of the body. So that is an important thing to remember. Okay, before we go there, I just want to make sure that so far, everybody is understanding everything I said so far, because I don't want to go further without people understanding the steps I've talked about so far, because throughout these dandy meetings, we're going to build on principles. And unless you can understand the basic elements, you will not be able to understand the more complex aspect of this. So I just want to make sure that if anybody has a question or don't understand what I have said so far, please do not be shy and feel comfortable to ask, because I don't want to be in a situation where you're like, wow, I don't understand what this guy's talking about. That will not be helpful, all right? I don't know people on YouTube if they can communicate with us or not, but I just want to make sure they're able to ask questions or interact with us, okay? So do not be shy, please. Be comfortable to talk to me in any way, shape, or form that you want. And I'm gonna repeat a lot of things just to make sure, because this is not easy, and it took me a long time for me to understand it. When I started as a resident, this is not so easy to understand. When you're starting as a resident, this stuff is not so, it's not defined in books, and three-dimensional pictures in books cannot explain what I'm telling you, okay? So that's why I want to make sure you're following along with me here, okay?
Actually, can I ask a question?
Yes, please do ask a question.
That it's important to measure and to know the direction of blood flow in anterior communicating artery pre-surgery.
Yeah, yeah. I mean, essentially, let me go back to the picture. So essentially, what happens? The blood flow in the two carotid arteries coming up this way. Obviously, is going. It's all forward blood flow. So carotid artery, anterior cerebral artery, blood flow going to the middle cerebral. So blood flow is going this way, this way, this way, coming up, going this way, this way. Now, once you come to the anterior cerebral artery, the blood flow from the left side should go to the left A2, from the right side go to the right A2, the left side will go to the left, to this A2. Now, if this is very small, this A2, you have an anterior communicating artery. So this vessel could supply this one and that one. If this is very small or is not functional, then this anterior cerebral artery can supply both the right and left anterior cerebral artery. This is why we have this redundant system called the circle of Willis. What this allows, if something gets closed, the other side can replace the blood flow, because blood flow in the brain is very critical. And this is why the circle of Willis is of tremendous importance to connect a lot of blood flow to each other. So that was a very good question. Okay, next.
Thank you.
Sure. Next, let's now see, how am I gonna get here? How I'm gonna get to this area, okay? Before we do that, I wanna show you something. I wanna show you where this area is. Okay. I have my skull. This skull was given to me as a gift from one of my professors when I was a first-year resident. I still have it. And to me, it was one of the best gifts I ever had, okay? And I'm gonna be teaching this, I'm gonna use this skull in a lot of lectures that I'm gonna be giving you over time. So you guys will get to know him very well, okay? Let's see here. So to enter the area we want to enter from the right side right here, just behind the right eye, okay? Why am I gonna enter here? I will tell you in a minute. Why is this is the area that I want to go into, okay? Sure you can really see this. The idea is that the whole circle of Willis I'm talking about, I'm sure you guys can see this.
We can see it, Professor.
Okay.
Don't worry.
The whole circle of Willis I'm talking about, those vessels I'm talking about, that circle sits right here, right just in that area right there. This is what we call the clivus, and this is the edge of the sphenoid wing here and here. So if I'm going for any aneurysm with the anterior cerebral artery, it's going to be sitting right there, okay? This is the area of the temporal lobe, and above it is the frontal lobe. In between is the sylvian fissure that I'm going to use to come down, 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 down here to get into the area of the circle of Willis. This foramen is the optic foramen. This foramen is the optic foramen. So the two optic nerves are going to be sitting right here, right below the anterior communicating artery. And I'll show you exactly how the anatomy works. So to get to this area right here, we do what's called a terional craniotomy, which is right here, which is at the level between the frontal and temporal lobes, will get you to the sylvian fissure right away. Because we need to get to the sylvian fissure to take that highway to get down there, okay? All right, so let's see. Let's go back and share. Now, I'm going to be doing, multiple lectures on aneurysm, so don't be like, why I don't get this. No, we're going to explain it in other lectures as well, so don't be thinking that you're not understanding it, okay? So what am I trying to do by this terional craniotomy? See, essentially, by having an incision like this behind the hairline, by removing a bone right there, which is right here, it puts me in between the temporal lobe and the frontal lobe. In between is the sylvian fissure. And that's where I need to enter to get down where I want to, okay? And once I open the bone, I will open the dura. Once I open the dura, I'm going to be seeing the brain and the sylvian fissure. Once you get underneath deep here, below, you will see the right optic nerve, the left optic nerve. What are we going to see? We're going to see the carotid artery, as we said, coming up. It divides into what? Middle cerebral artery, anterior cerebral artery. The anterior cerebral artery is going to go what? Connect with the anterior cerebral artery from other side, forming the anterior communicating artery. In our patient, this aneurysm is sitting right here. Then we're going to have the A2 of the right side, the A2 of the left side. That is what we've got to be looking at to do the surgery we have gotten ourselves into here in this poor patient who just had a hemorrhage. And we're going to be doing this surgery together right now. I just want to define to you what a craniotomy looks. So the first step is we're going to do a craniotomy. Then we're going to open the sylvian fissure. And I'm going to show you that. This is what clipping is. When I talk about clipping, it's putting a clip on an aneurysm. It's like this, okay? That's a clip on an aneurysm. This is this is a situation, okay? This is how the patient is set. Okay. So we're gonna do this craniotomy right here, okay? We're gonna remove that bone right there. Temporal lobe, frontal lobe, we want to enter the sylvian fissure. Now, once we get to the sylvian fissure, what are we gonna do? Well, this is what we're gonna do. We open the dura, like I showed you, temporal lobe, frontal lobe. To get in between, we have to do what's called splitting the sylvian fissure or opening the sylvian fissure. Essentially, obviously, as you know from what we've shown, the middle cerebral artery is going to be sitting right here. That's going to be the first vessel we're going to see, okay? We have this layer, what's called the arachnoid, which covers the blood vessels, and that's the layer we're opening. Now, the arachnoid has no neuronal cells, so we can open it, no problem, okay? So the three layers that cover the brain is the dura that we just opened. The arachnoid is this right here, this grayish color. The pia is adherent to the brain. You cannot separate it from the brain, okay? The space between the arachnoid and the pia is called the subarachnoid space, okay? That is the space. All the blood vessels of the brain sit inside the subarachnoid space. Without opening the arachnoid, you cannot get to the blood vessel. You cannot get to the aneurysm, okay? So the space that we need to be in is between the arachnoid. After we get in, we have to open this arachnoid to get to the subarachnoid space, the space that is where the blood vessels are, where the aneurysms are, and everything else, all right? This, what you're looking at, what I'm doing, suction in my left hand, micro scissors in my left hand, is opening the sylvian fissure, okay? You see, I'm opening the sylvian fissure under the operating microscope, okay? I have to be careful I don't injure any blood vessels, obviously, okay? And this comes with a lot of training. This is how we teach residents how to do microsurgery, is by opening the sylvian fissure. Before we go to the aneurysm we are talking about today with this patient, I'm going to show you a couple other surgeries just to show you the techniques. This is a patient who has an aneurysm on the middle cerebral artery inside the sylvian fissure. She already had bleeding. This is called subarachnoid blood. This is bleeding from an aneurysm before. So now I'm going to teach you techniques as to what I need to do. The next step you need to learn, you have the aneurysm, obviously is a very dangerous structure. Essentially what you need to know, there are two types of arteries that you have to worry about. One are the major arteries, like we talked about, the anterior cerebral artery, the middle cerebral artery. Obviously, if you close one of those permanently, the patient will have a massive stroke. The second type of arteries is called perforators. These are small arteries that supply critical areas of the brain. And these arteries can be very small, and you, by mistake, can occlude one of these and cause a stroke. And sometimes they're very difficult to handle. What are you thinking once you're looking at this aneurysm? As a neurosurgeon that's early in his or her career, you're scared, because what will happen if this aneurysm ruptures on you and bleeds like crazy, the patient can die. So all you want to do is clip this aneurysm and get the heck out. You want to get out of here. You want to clip this aneurysm, you want to leave, okay? But you have to be smart. If you clip this aneurysm and you clip one of those perforators inside this aneurysm, the patient can have a stroke after surgery. So you have to be smart. On one hand, you're very worried that you're going to do something and this aneurysm will rupture. You just want to clip on it and leave, go home. On the other hand, you want to say, listen, I want to be careful. If there are any tiny arteries here, I need to know where they are before I put the clip. These are the two things going in your head as you're doing the surgery, okay? Wow, there's a perforator right here. The problem is this perforator is stuck to the wall of the aneurysm. Well, I have two choices. So listen, let's not be heroes today. Let's put a clip on this aneurysm. This perforator is stuck to it. We'll close off the perforator. It's okay. The patient may have a small stroke, but I don't want any problems. I don't want this aneurysm rupturing on me, okay? The more experienced vascular neurosurgeon says, hell no. I am not putting a clip on this aneurysm until I know that this perforator is safe, is not closed off in my clip, okay? So that's the dilemma of the experienced neurosurgeon versus a novice neurosurgeon, okay? So what you're gonna see me do here is very carefully, I'm gonna separate this perforator from the dome of the aneurysm, okay? Now this takes experienced vascular neurosurgeons to feel comfortable with what I'm doing here, okay? This is a comfort level issue, okay? And see, I'm looking behind the aneurysm. I'm being very, very careful. You see the blood inside the aneurysm is rolling, okay? This is a big M2 division. M1 is down here, M2 here. But this is a perforator, okay? See, I'm being very, very careful not to cause a problem, okay? Now, let me tell you something else before we move on. Now, if you are not an experienced vascular neurosurgeon, the first thing you do before you touch this aneurysm or perforator, you put what's called a temporary clip. You close off the middle cerebral artery temporarily, so while you're working on this, if something bad happens, you have at least stopped some of the flow coming into the aneurysm. Now, as you become a very experienced vascular neurosurgeon, you say, okay, if I put a temporary clip, I put a clip here, the blood is not going to the brain during those minutes that I'm doing this, so I'm possibly hurting the patient during those few minutes. So I want to not do that. That comes with experience. If you are a novice neurosurgeon, you 100% should put a temporary clip here, because if something bad happens, you will not be able to control it. A very seasoned neurosurgeon can do all this without a temporary clip. So I want to make sure I'm sending the right message, and so nobody does anything dangerous, all right? This patient had multiple aneurysms, but that's fine. See what I'm doing here? I'm now, boom, separating the perforator from the aneurysm. It doesn't take much to tear a hole in this aneurysm, okay? Just so you know, okay? So this is where you have to be just good at what you do. You have to be very experienced. You have to be very confident. And this is what I'm doing through this dandy club. I want to make future experts, masters. You see how am I separating? Nice. Now I'm feeling really, really good, because if I can separate this, I can clip this aneurysm without causing a problem. Now it's a different ball game. The aneurysm is free from everything else. I can clip this aneurysm, go home, and not worry, okay? Let me show you another case of the middle cerebral artery. Okay, a big aneurysm. We're coming in from the right side. We just opened the sylvian fissure. Temporal lobe, frontal lobe, carotid artery, M1 divides into M2, M2, the two divisions. Big aneurysm. Now this is forcing a whole nother problem for us. The problem with an aneurysm this big, that's partially calcified, is that if you try to put a clip on this right up front, the clip will slip, it can tear the aneurysm. So I'm gonna do another maneuver that I'm gonna be showing you in a minute. Again, if you are a neurosurgeon that's not doing these kind of surgeries, you want to put a temporary clip, close off the middle cerebral artery before you touch the dome of the aneurysm like I'm doing here, okay? That is something that you have to do before you mess with something like this. Now you see, I'm separating this big division from the aneurysm dome right there. You see, big, ugly looking aneurysm looking at me. You know, I have to be very careful, very, very careful. Every maneuver has to be very careful, okay? Now I'm gonna do something that, again, unless you've done hundreds of aneurysms, you never wanna do this. This is a technique I have evolved, which is shrinking the aneurysm before we put a clip on it, okay? This can only be done in very, very experienced hands, because doing the wrong maneuver here, you could tear the aneurysm. You see how I'm shrinking it? Shrinking it, shrinking it, shrinking it. You see what I'm doing? Right there. See, I've already made this aneurysm about 20% its initial size. You see that right there? I have changed the aneurysm size, the configuration within few minutes. Again, if you are a neurosurgeon, not, you know, first of all, you should have a clip, and secondly, you cannot be doing this unless you're very, very experienced, okay? So this is a different ball game, what I'm showing you, but I'm just showing you the possibilities what can be done. A lot of neurosurgeons around the world, when I tell about this kind of, they don't believe it. You have to show it in a video for them to believe it. Otherwise, they don't think this is possible, okay? So what I'm showing you is just is what can be done, okay? Now, I'm putting a clip. You see, the clip goes like this, not like this. So it goes against, parallel to the two A2s right here. Boom, that's the aneurysm clipped right there, okay? So M1, M2, M2 open. I put another clip just to make sure everything is open right there. We are cured for life, okay? That's a cure for life right there. Now we go to our patient that we talked about, okay? Before I do that, I just want to talk to you guys, make sure I haven't lost anybody in this process. Are you with me? Are you with me? Are you pissed at me or what? I want to make sure we are understanding what we're doing, why we're doing it, what is the idea behind it, what can be done by early, novice neurosurgeon versus very highly experienced neurosurgeons. I need to make sure you understand the different ideas, okay? And I want to make sure that you understand the principles of what we're trying to do. So before I start our case that we're going to operate on today, I just want to make sure if there's any questions, concerns from any of our colleagues about anything that I'm talking about here today, okay? And the other thing I added to this whole thing, those patients I just showed you, the problem is when you're putting a clip on an aneurysm, there are these perforators around it. or if you are putting a temporary clip on a normal artery, if the patient is under general anesthesia, you don't know what's going on with the patient. This is why evolved the idea of the ability to do awake surgery in aneurysm surgery. So if we could do awake surgery in aneurysm surgery, with the patient awake, we're testing while we're putting these clips on. If the clip is on for too long and the patient's having symptoms, I can remove it quickly. I know right away. And this is why that's another thing that I've added to our armamentarium of aneurysm surgery as we grow this specialty for the next generation, for your generation. Okay, so that's where we are there. Okay, if there are no questions, let's go and do our surgery. Now you have seen the principles. We're gonna follow the principles we talked about, and doing the surgery in this woman that had this hemorrhage, has this anterior communicating artery aneurysm. Okay, so let's go ahead and proceed.
Professor,
Yes,
there
please.
is consensus about how long you can stay with the temporal clip.
Yeah,
Or-
so one of the biggest issues are there is no formula you could use for how long you could put a temporary clip on a blood vessel of the brain. It is different from every person to every person, and it's different from every vessel to every vessel. So there is no mathematical formula you can come up with. So all these are generalizations. You know, in general, few minutes on some of the major arteries is tolerable, but it's not tolerable in some people. This is why my work in awake surgery and using temporary clips is producing some unique data for the field of neurosurgery. We're gonna publish data that tells us truly what the spectrum is of potentially how long temporary clip can be on or not on. So I'm gonna be really introducing unique data, because never before this have we ever known how long clips can be on or not on in an awake patient. So I have the first experience, so I'm going to be sharing this experience as we're putting this data together. So this is important, but in general, unfortunately, there is no rule. There is no such thing. I've seen some patients tolerate temporary clip for 5-10 minutes. Some people do not tolerate it for a few seconds. And that's a dilemma, okay? So that's important to know, all right? And that's why the awake surgery has been a game change as far as that's concerned, because it tells me right away, So that's important. Okay, let's go.
Thank you.
Oh, no problem. Okay, now let's go and do the surgery on this poor patient that we talked about. So this is it. Now, how are you going to look at this situation? Now, because you have been educated about this a little bit, I'm going to explain to you what you're looking at. Imagine you're looking from the right side of the head, okay? Just from the right side of the head, from that sylvian fissure I showed you. The carotid artery comes up here and divides into the middle cerebral artery, anterior A1 on the right side, A2 on the right side. What are we seeing behind the aneurysm? That's the A2 on the left side. That the A1 on the left side is on the across the other side. So we're looking, if you captured what I'm trying to explain to you, hopefully this is explaining. But there is a big problem. That recurrent artery Hubner I talked to you about, supracurricular perforator, is sitting right on top of the aneurysm, not making my job easy, okay? It's upsetting me, it's pissing me off, okay? Just so you know, all right. So that's what we got. That's what we got from different angles. I'm looking at this before surgery because I'm trying to make a plan, all right? And this is how I want you to think. You have to think like a commander, a general of an army going into war. Okay, we're gonna remove our craniotomy, fine.
For anterior communicating artery aneurysm, I do not recommend the subfrontal.
Some of this is for neurosurgeons, so don't worry about some of the lingo.
That trajectory in itself has a higher risk to injure the pia of the subfrontal cortex due to increased retraction. I do recommend, however, the Transylvian trajectory. What that allows is for further opening of the carotid cistern and exposing the A1 early, yet with minimal retraction. I would like to discuss with you the trajectory for this anterior communicating artery aneurysm. We will be approaching the right A1 first, which is right here. And we, of course, will be identifying the right A2 right here. The left A2 is here. And an important structure that's going to be critical for this operation is the right recurrent artery of Hübner. What we need to recognize prior to surgery here, that there is a good chance that this recurrent artery of Hübner will be sitting on the dome of the aneurysm itself, and it may be attached to it. Now that becomes a key technical issue that we need to be aware of. The left A1 is seen very in the background here. So what we know at this point, that during our approach, we will be looking at the aneurysm from the right side, and we will be coming at this juncture at which we will see the A1, A2, and this important structure being the recurrent artery of Hübner. We will then have to identify the left A2 and, of course, left A1. So that becomes the strategy for the surgery and the limitation that comes with it.
Okay, so I just want to explain to you what we're looking at here. So we came in through the sylvian fissure. The carotid artery is here, right side. The middle cerebral artery will be going this way. The anterior cerebral artery is going to be going this way. Right optic nerve, left optic nerve, optic chiasm.
So we're looking here at the right optic nerve, and this is, of course, the left optic nerve. This is the area of the chiasm right here. And this little area right here is the lamina terminalis. From a vascular standpoint, what we are looking here at, as you know, this is the right A1, the left A1, and we are just coming close to the area of the aneurysm right here. This is the ICA on the right side. So at this point, our dissection was opening of the sylvian fissure, then opening, exposing the optic nerve on the right side as well as the left. And now we are coming close to the dome of the aneurysm, as you can see here. And we are just looking at the superior portion, right A1. And this is the right A2 here. Let's now look at the aneurysm itself in a little bit more detail. So this is a wall of the aneurysm right here. Right there. That's all aneurysm right here. And obviously we talked about in the preoperative planning, which is this key vessel right here. The recurrent artery of Hübner attached to the dome of the aneurysm. That becomes our challenge here at this point. And how we deal with that specific vessel will obviously have an impact on the outcome of the patient. So at this point, the first attempt I'm doing here is try to dissect the recurrent artery of Hübner off the dome of the aneurysm. My first attempt here, as you see, is to sharply dissect the vessel. That is possible in cases where there is a plane between the vessel and the aneurysm. As you could see here, I was not happy with the plane. I did not want to take the additional risk. At this point, I'm looking at the right A1 to identify a good area to put a temporary clip on. Always find an area where there is no perforators behind it. What I'm doing at this point with a temporary clips on the right A1 and the left A1 is to reconfigure the shape of the aneurysm with bipolar coagulation on either side of the recurrent artery of Hübner. So what I'm doing here now is under very low power at 20, the bipolar, not using the tips, but the side mostly to reconstruct the aneurysm around the recurrent artery of Hübner so that the final clipping will be safer while protecting the perforating vessel. As you see now, I'm starting to expose the left A2, which is very important for us to see right here. The left A2 was very important so that we could see that behind the aneurysm. And I'm dissecting here between the aneurysm dome and the left A2 so that we could see the edge of the aneurysm on the contralateral side. And you're seeing the left A2 right here. This is a left A2 right here. You see that? And this is the dome of the aneurysm, so that I'm dissecting now behind the aneurysm to make sure, now I'm behind the aneurysm, making sure that there are no posterior perforators behind the ACOM aneurysm, which are very critical, because this is where deficit occurs in memory and so forth when these perforators are incorporated in an aneurysm clipping in the ACOM region. And now you see I'm very sharply, what you will note, I'm not using any blunt dissection. Now I'm bipolar coagulating. I'm bipolar coagulating the aneurysm dome itself. That is giving us additional space now to work behind the aneurysm. You see now I'm going back sharply behind the dome of the aneurysm to make sure there are no perforators in the posterior wall of the aneurysm. If we had not done this, you could imagine we would not be able to see behind the aneurysm. If we just put a clip like we would do the standard, we would not know. Every 2 minutes, I will open the temporary clips to recirculate. So there is no reason to leave a temporary clip on for 5 or 10 minutes. Every 2 minutes, I will open the temporary clip and continue to work. This way, you avoid risk of ischemia during aneurysm surgery. And I use the standard all the way around. Now, this is a permanent clip application at the neck of the aneurysm. I'm not happy with the back wall of the clip, so I'm going to reposition and angle the clip more posteriorly so I get the whole aneurysm in the clip itself, as you see here. So now I have the aneurysm clipped because I can see all the way around it circumferentially, and the recurrent artery of Hübner is preserved, as you can see. So we are now in good situation, looking at the anatomy on either side. Now this is the ICG angiogram. You're seeing the right A2, the left A2, right there. And this is a recurrent artery of Hübner, just at the tip of the clip, completely open.
Okay. So that was our patient that we just finished surgery on. And just to show you the data on the awake surgery that I do, that this was the first 30 patients we did when we, this was the first publication in the field of neurosurgery of awake aneurysm surgery. My first 30 patients compared to the large data banks, government-based data banks of large academic centers in the United States, thousands of patients. Length of stay for my surgery, 3 days, or for the other centers, 5 days, 7 days. Discharge to a facility, not home, meaning going to a nursing home or rehabilitation, 16%, 16%, 17%. In the awake surgery, 3% only. Stroke risk, 7%, 8%, 9%, 14%. In my surgery, 3%. Modified Rankin scale, meaning how's the patient doing after surgery, not available for these large data banks. 1 meaning the patient going back to their normal life. Mortality 0 in the awake cases is very small, otherwise 2%, 1%, whatever. So that really is what I wanted to share with you today, is a conglomerate thinking of a specific aneurysm, the thinking, the surgery, the techniques, the thing. Even I, as you saw, times I'll use temporary clipping. So you see, you pull all your judgment, the right thing to do for every patient, to do the right operation to get them through it. So that's really the big picture of the thinking behind aneurysm surgery, how it can be done, and the various techniques. Obviously, when we evolve together over time, we will talk about more complex cases. I'm going to talk to you about more calcified aneurysms on the basilar artery, which adds another element of complexity. Then I will talk to you about doing bypass surgery when an aneurysm cannot be clipped and I have to close off the parent artery and add a graft. All these things we're going to talk about over the next few months. I just want you to grow with us, in understanding this, I want to open up for any questions you guys have. Thank you for the nice comments for all of you guys. I appreciate that. So please feel comfortable to ask me about anything you saw, anything that's bothering you don't understand, any ideas.
I have a question.
Yes, Clarana, please.
I was wondering why I would do a neurosurgery rather than an endovascular procedure for the aneurysm.
Yeah, that's a very good question. So we utilize both techniques for the right patient. The big picture is the aneurysms, the idea of aneurysm treatment are two things. One, you want to do the treatment without complications. Number two, you want to achieve cure. Okay? The cure issue is far higher with open neurosurgery than it is with the coiling. With open neurosurgery, the cure is close to 99%. With coiling is about 60 to 70% in most kind of aneurysms there are, okay? So there is a segment of the people, not only you had the coiling, then you still have to have the open surgery. So that makes even adds more risk. That's one. Secondly, there are certain factors that are better to clip versus coil. The factors better to clip, younger patient, because they're going to live a long time. You want to achieve cure. And for aneurysms that are in the anterior circulation, and I'll explain that later, are better for the clipping. Coiling is better for older patients, for medical comorbidities, and for basilar tip aneurysm, because basilar apex aneurysms are quite risky with open microsurgery. So you have to make the decision based on the patient. But the most important decision really has nothing to do with the patient. It has to do with the experience of the center where the patient is, okay? If my sister had an aneurysm and she's at a place that I know they are very good with the coiling and they're okay with the clipping, I want it to be coiled. If she's at a place where they're master surgeons in clipping and they're okay with the coiling, I want it to be clipped. So that's a subjective issue, but it's very important because the experience I just showed you is very steep curve to get to that experience. So if somebody is not at that level, I wouldn't want them to be operating on my sister. I'd rather if they coil that aneurysm versus if it's a very experienced person in microsurgery and my sister is young, she has an anterior circulation aneurysm, I want it to be cured, I would want the surgery done. So it depends on the experience of the center. How experienced are the people, the surgeon in doing these surgeries? Have they done hundreds or have they done 10 or 15? Big difference, okay? So those are the things, the benefit risk ratio that showed. And I'll be, to put humility aside, I put my numbers against all the outcomes for coiling. So in experienced hands, I can achieve just as good or not even better risk of the surgery or the treatment, but then I also have a better cure rate. So on both factors, I can be better. Now that's one thing, but it depends on where you are and who's doing the procedure and how experienced they are. So so those are all factors that are very, very important. There is no cookie cutter model. What you see published in the data does not apply at that hospital where your mom is not going to need to have that procedure done. You need to know those teams, how good are they? What is their complication rate in open surgery and in coiling? Coiling can have just as easily strokes and all kinds of things. Just because it's not an incision, you don't want to think that it's not going to cause major problems. So you have to know those things to make the right decision. So that's a very good question. Very good. Let's see. Thank you for all the nice comments from everybody. Yes, neurosurgery is an art, for sure. Neurosurgery truly is an art. Neurosurgery, microsurgery, what I just showed you is what's called microneurosurgery. To me, this is the soul of neurosurgery. This is the soul of why I entered neurosurgery. It is doing that fine, like an artist, doing fine, detailed work around tiny blood vessels and having the confidence to do that kind of work. That was the love affair I had with neurosurgery. That's why I went to neurosurgery, okay? And that's why I choose to do that. That's the only area I work in. This tiny little area I showed you here, I spent all my life in this golf-sized circle. Like most people spend their life in the Caribbean, the Greek islands, in Brazil. I spend most of my life in a circle as big of a golf ball, okay? That's what I live, okay? So I've spent more time there than on any island or traveling or anything else. That's what I've spent hours and hours of my career working in such a tiny area. I know it like the back of my hand. I know it better than anything else. But that's what I want you as future experts to be. I don't want you to be mediocre, as I said. I want you to be experts. So I lived up to my own motto. I said, if I'm going to do this, I want to be really, really good at it. I want to be really good at it. So when I go home at night, I know, you know what? I did my best. And even if there is a problem, it's not like there are other people who could have done it better. Okay? That makes you feel really good about yourself. It's not like you did something bad and you feel bad about it. No. You did the best, and it's not like, somebody else could have done better, okay? That's a stage I want each one of you to reach in your life, in your careers, is to get to that point where you have that level of confidence and, confidence, but humility and believing and doing what you do. So I think that's an important lesson that I want you to. So today we talked about the anterior communicating artery. Over time, we'll be talking about different regions of the brain, different aneurysms, different vascular malformations, but the principles are all the same. The deep principles are the same. The idea, the mentality, the confidence, the humility are all the same. They do not change. They all stay the same all along. So that's really the idea of what we're trying to achieve here. Thank you. Thank you for the nice comments. Are there any other questions that I can answer for you guys? No burning questions from anybody about the things we're doing here?
Professor, I have a question.
Okay, please go ahead.
Do you use the same axis through the Sylvian fissure for all aneurysms in the Willis circle?
Yes, Giovanna, that's a very good question. The Sylvian fissure is my highway. I spend, I'm inside people's Sylvian fissures at times 3 times a week or something. That's the main highway. So most of the aneurysms of the circle Willis our approach to the sylvian fissure. Now, there are certain aneurysms, maybe sometimes the basilar artery that we may approach to a different direction, or the aneurysm, the vertebral artery, we will go through a different direction. But most aneurysms, exactly, is through the sylvian fissure. The sylvian fissure, once you learn it, you know it, you get down there, it is your way to treat most aneurysms, skull-based tumors, tumors around the optic nerve, tumors around the pituitary gland. Everything is right in that tiny little area. So once you master that, it opens up a whole spectrum of things that allows you to live in that area and to do well in it, you know? So that's very good.
Thank you, Professor.
Professor,
Yes.
about the procedure that shrinks the aneurysm dome.
Yeah.
What is your complication rates and the main complications?
Well, I mean, if had complications, I would stop doing it. It's really, the main thing is with that is that these aneurysms sometimes require multiple clips and becomes very complicated. For me to shrink it, I can make it very simple. The only out of the hundreds of aneurysms done with this with, I've had bleeding a couple times, I was able to control it very quickly. Now, before me, Professor Yashigil did this on tiny little aneurysms with the bipolar, and then I advanced it to these large aneurysms, okay? Now I think it's an amazing technique that changes the whole game. The problem with it is that you have to be really adept at how you do this, okay? And that's why I say to people who are early on in their vascular neurosurgery not to try this. This is somebody who's very senior or high up in their career in vascular work, microsurgery, to do it. So those are the important elements. Let's see, there's a question here from Dr. Wan. How do you choose side of your approach based on the position of dome of the flow? Okay, so for anterior communicating artery aneurysms, you have this very amazing option. You can go from the right or left side because it's right in the middle, okay? Now, if you have an aneurysm in the middle cerebral artery, you go on the side where the sylvian fissure is, right? If you have an aneurysm of the carotid artery, you go to the side of the carotid artery. Now, of the anterior communicating artery and basilar arteries, you have the option of either side. So you decide based on a number of variables. In general, for anterior communicating artery aneurysms, I prefer always go from the right side because the left side is the dominant side for speech. So if you had any problem, you will have, you risk speech as well. So I always choose the right side in general. I mean, I rarely ever will go from the left side. That's my idea for anterior communicating artery aneurysms. And I rarely ever would, unless there's some vascular reason, would go in from the left side. Okay, so Liv is asking the question, is there a possibility of hurting the tissue around if you're using the clips? Well, that's why you're being so careful, Liv, when you're putting the clips. Not just the back of the clip, but you've got to know where the tip of the clip is. If you occlude a perforator, obviously there's going to be complication. If you enter a brain tissue, that's important. So you got to be thinking about all that. I mean, the whole length of the clip, where it closes, where it's sitting, where the tip is. Yes, it's very important. I mean, you know, that's exactly right. So that's those are all principles that you have to think about and grow as a surgeon to be thinking about. All those little things add up to become important variables. Yeah, of course. Yeah, no, thank you for the nice comments. Well, it sounds like it's been a great opportunity again to meet with my good friends, with my officers in Brazil, with our students and neurosurgeons who have joined as our guests. Until next time, we will evolve this into a curriculum. We're trying to develop a whole curriculum around brain surgery that the Dandy Society is gonna superhead. And over time, you will see this whole initiative develop into something much larger. But the idea is to teach you through these sessions, different parts of the brain, different techniques, different access, just so that you could develop the idea of what brain surgery is like and this kind of micro neurosurgery of the brain. So it's been It's been a great pleasure to all. It's really good to see you all.
Thank you very much, Professor, for this
Alright.
amazing and inspiring lecture. And thank you everyone from our club and for everyone that watched us. Thanks for being here and to support us.
Great. Good to see you all. Take care.
Thank you. Bye, Professor.
Bye. Bye.
See you.
Bye.